when it comes to education, there really is a lack of healthcare education curriculum. I truly believe this does perpetuate a sense of invisibility, especially to that young medical student who is not out and feels invisible in the workplace. Having education will also reduce biases from other people who have never even met a queer person or taken care of a queer person in the workplace as well.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD.
Hello, everyone. Welcome to another episode of Parallax. Thanks for tuning in on another Monday. My guest on today's show is my dear friend and colleague, Dr. Stephen Cook, who I've known now for 3 years. So time flies, Steve. So Steve and I first crossed paths in the state of Indiana, in Indianapolis, and I can say that we've always been at the same institutions ever since we've been in Indiana. So we're both at Franciscan Health now. Steve is a cardiologist at Franciscan Health. He's also the chair for the LGBTQ plus work group for the American College of Cardiology, and has published, I would say, a tour de force paper recently in JACC Advances. The title of the paper is Experiences of Lesbian, Gay, Bisexual, Transgender, and Queer Cardiology Physicians and Fellows in Training. So with that introduction, and without much further ado, Steve, welcome to Parallax. Welcome on the show. Thank you so much for doing this for us, and congratulations for such an impactful and an innovative paper.
Great. Hey, thanks for having me on the show. I really appreciate it. I just want to share with everybody who may not be familiar with the LGBTQ plus work group. We actually established this work group about 3 years ago. This work group is really a safe space for anybody who's interested in joining. We've had a growing number of professionals as well as allies who have been interested in joining us within our LGBTQ plus work group. This is a great group if you're interested to help build a community for all of our ACC members who are interested in facilitating professional development, research, and educational opportunities and mentorship for future queer generations of cardiologists. And it's really through this work group that we thought of developing this research project, and to kind of really help us understand the experiences of lesbian, gay, bisexual, transgender, and queer cardiologists, as well as fellows in training, as we've really never kind of understood this background before. So we were really interested in kind of understanding, what do LGBTQ plus physicians experience in the workforce? And is there harassment? Is there something unique about this patient or about this physician population? Why is this so important and important to us in general? Well, we know that there are about 25 million adults who identify as LGBTQ plus. And we know that, consistent with other minority health or minority stress models, we know that the internalization of negative healthcare experiences can also be specific to LGBTQ plus people as well. We know that there can be a fear of disrespect or mistreatment related to gender identity. There can be negative interactions with healthcare providers. And if you combine that with general life stressors, this can certainly contribute to cardiovascular healthcare disparities for LGBTQ plus adults. Meanwhile, the number of Black, Hispanic, and Indigenous American healthcare professionals have been increasing, but there's been a really gross lack of data about the proportion of LGBTQ plus physicians. And I think that really stems from the fact that we don't collect what we know as what's called sexual orientation and gender identity data. When you look at specific studies that have been done in the past, I know that Lakshmi Mehta has done a great amount of interest in looking at understanding our workforce, our cardiovascular fellow workforce. But when she investigated this data, she merely looked at sex. And so she looked at males and females undergoing cardiovascular training, whether it was pediatric cardiology or adult cardiology workforce training. But, everybody has a sexual orientation and gender identity that can be easily and reliably measured. But there's really, if you look at cardiovascular research, there's just a lack of investigation of this type of data. And so what we did in this study, not only did we include traditional demographic data, whether that included race, ethnicity, age, marital status, we also included what's called a two-step gender identity question, which is pretty straightforward. I mean, these are just two simple questions that ask, what is your gender identity? And followed up by, what was your sex assigned at birth? And so for folks who may not understand gender identity, I'll just provide some simple definitions as well. So this includes, are you a cisgender male or cisgender female? And again, the term cisgender is just really, what is my internal sense of gender that correlates with your sex that you identify with birth. So I am a gay cisgender male. So that simply means that my gender identifies with the sex that I was born with. So I'm male, and my sex identified at birth was also male. But then there is transgender male and transgender female. And so just the term transgender, which is simple to understand, this is an umbrella term that's used for people whose gender identity is different from the sex that they identified with at birth. And so that's basically how we would identify gender identity for the participants who participated in this study. We then really wanted to get a sense about what types of harassment LGBTQ folks or cardiologists and fellows in training may have experienced as either cardiologists or as fellows. And so we chose to look at what's called a short negative ACTS questionnaire. And this is a nice validated 9-item tool that really just looked at bullying in the workplace. And then specifically, we wanted to look at forms of harassment that may have been more specific to the LGBTQ plus population. So we then focused on 2 very specific forms of harassment. The first is called gender policing harassment. And this is a form of harassment that specifically looks at gender harassment, that is characterized by negative treatment just from deviating from one's traditional gender role. The second type of harassment that we looked at is heterosexist harassment. And again, this is a distinct form of identity-based harassment that really targets individuals who either deviate from the norm by simply being LGBTQ+, or even just perceived as being LGBTQ+. And so not only do we look at those forms of harassment, but we also wanted to find out where that type of harassment was coming from. So we looked to see if this was coming from a patient or a family member, leadership personnel, if it was from an attending cardiologist, colleagues, administrators, and support staff. So looking at our results, I think we had a fair amount of respondents. We had 188 respondents who completed the survey.
I want to pause and sort of dissect some of the methods that you employed. But first off, congratulations on identifying that there is a need to study this topic, scientifically, methodologically. For those of us who are interested in understanding how to access these questionnaires, and learning more about them, I think it will be helpful for researchers with interest in the same space who want to conduct similar research projects. I think it'll be helpful and interesting for them to know where to find these questionnaires, how to access them, and how to understand them better as research tools. I don't know if that's a fair question to ask you, but I think as as a researcher myself, I was very interested to learn more about, how you went about, finding these questionnaires, and then also the construct of the survey. I think, is it something that you have to get approved by the college before you disseminate it? And then, also like the dissemination vehicle for the surveys, was that sort of the ACC's listserv that was utilized? Was that a particular work group's listserv that was utilized? If we can sort of find, if you can just extrapolate on some of these questions that I've asked, I think it's going to be helpful.
Yeah. So a couple of things. No, those are great questions. So one, yes, we did have to get approval from the ACC because you're exactly right. We used two specific listservs, right? We used the fellow in training and the early career cardiology listservs to identify respondents for this survey. We actually specifically to kind of make sure that we did not get folks who would be interested in, to kind of eliminate bias for the survey, right? We called this a gender minority survey. We didn't want to get folks who are saying, oh my gosh, this is an LGBTQ plus survey, so I'm going to participate in this survey. Or we didn't want to turn off people from participating in this survey either. So we kind of specifically just called this an ACC gender minority survey to kind of make this really welcome to all respondents. There's a lot of, we still learned a lot of information from our non-LGBTQ plus respondents about harassment in general. And we learned that a lot from the short negatives acts questionnaire. That's applicable to all respondents, whether or not you're LGBTQ plus or not. So I think that was incredibly helpful as well. As far as, I think there is whether or not, asking sexual orientation and gender identity data, there is a lot of information that you can get from the Fenway, which is a LGBTQ plus information center in Boston. Kind of gives a lot of really good, helpful data about how to appropriately ask sexual orientation and gender identity questions in a survey format. The two-step gender identity questionnaire as well is also approved through multiple transgender. Let me make sure I kind of say this appropriately. It's also approved through numerous transgender surveys throughout the US as well. So this is not something that we created on our own. And so most sexual orientation and gender identity questionnaires, I'm actually going to pull up the questionnaire that we included in terms of what did we ask. So this is pretty straightforward what you ask in a sexual orientation and gender identity. So for sexual orientation, we asked whether you were heterosexual, lesbian, gay, bisexual, queer, asexual, pansexual. And what I think is incredibly important to ask in sexual orientation and gender identity questionnaires is always to include other as a write-in for anybody participating in a survey like this. And just equally as important is prefer not to disclose. So that way you're being as open and inclusive to every single person participating in a study like this. And we did the same thing for gender identity as well. So not only did we include cisgender and transgender options, but we included many other options such as non-binary, genderqueer, agender, and again, other, and prefer not to disclose. We included this, your question is incredibly important, and we included the survey as a supplement to the article, again, as a reference, so other people can start either incorporating this survey as kind of almost as a reference point if other people are interested in including this data to become more inclusive, to include sexual orientation and gender identity data points for other future surveys.
Yes, no, thanks for delving into some of these methodological details, because if colleagues want to, emulate some of this work from a methodological perspective and study similar topics through the mechanism of surveys, then this is going to be very helpful. It's sort of like the playbook, the roadmap. One more thing is like if you identify a group of interests that you want to survey, and you develop a questionnaire, how do you go about sort of building consensus within the college that this is something that should be done or needs to be done or needs to happen? I mean, who sort of comes up? I mean, I'm assuming that in this scenario, you were the one who wanted to do the survey, or maybe someone came up with the idea and you said, this is a great idea, let's get this done. How do you build consensus within the college? I mean, if, for example, if say a fellow in training who's listening to this has a burning question and wants to survey colleagues, how does that fellow, he or she, goes about getting this executed and getting responses?
Yeah, that is, I think it's a matter of bringing it up to, there's many avenues. So if they wanted to use one of the listservs, it would be an interesting thing. It depends on how you wanted to bring the survey to fruition. So let's say you wanted to do another survey through the like FIT listserv. It might be interesting to bring it up to the FIT council and kind of bring it up through that mechanism, and see how can I work collaboratively, or even collaboratively with the LGBTQ plus work group, and say, how can I work together with you or with members on the team to kind of bring my research project to fruition. And that might be a way to work collaboratively through us. Or, what if I have a project that I want to look at LGBTQ plus people, but have a question for program directors. You know what I'm saying? So there's many other ways to kind of survey, queer people or queer populations through the ACC.
Yeah, no, excellent. So let's get into the results, because that's the meat of the paper. And I was really fascinated to see one. And for listeners, I mean, you've got these very nice tables and figures where you can essentially dissect this paper. I mean, that's how I read papers anyways. I just go to the tables and the figures, and then I just come up with my own conclusions and then read the discussion. So I'm going to have you go over the results with us. Start by talking about the folks you heard back from. I mean, what were the characteristics of the people who responded to the survey?
Yeah, so this was exciting for us as well. So we had a total of 188 respondents who completed the entire survey. About over half were fellows in training. And I think this was what was exciting for us. About a third of the respondents, or 62, identified as LGBTQ+. 25% identified as lesbian or gay, 6% as bisexual, 2% as queer, and then 1% identified as another sexual orientation. 5% identified as transgender or non-binary. So for me, that's a pretty exciting breakdown of the respondents for this survey. If we look at, for us, which is exciting, but not enough to really dive deep into this population, about half, or 52%, were white, 28% identified as Asian. We had 16% identifying as Latinx, 6% were Black, and then 5% were Middle Eastern or North African. We talked about where they were in their career stage, and we talked about their gender identities. So I think there was a good variety of race and ethnicity, and clearly a good variety of how they identified as LGBTQ+.
Yeah. So, I mean, the one thing which stands out to me, I mean, if you look at fit and early career, if you put those together, I mean, that's like almost 80% of the respondents. In comparison with mid to late career or, non-MDs. What do you make of that, Steve? I mean, is there more awareness? Is there more education? Is there more acceptance?
I think there's one really interesting thing. If you start to look at Gallup poll data, there's one interesting thing, if you look at Gallup poll data about, if you look at US Gallup poll data, what's happening over the last several years, they will report that about 7.5%, I think it's now up to 7.6% of US Americans identify as LGBTQ plus in the year 2023. But it's interesting, they start to break down who identifies as LGBTQ plus. They break it down as by Gen Z, millennials, Gen X, etc. About 23% of Gen Z identify as LGBTQ plus. And I think that I cannot say this with 100% certainty because we did not study that in this paper, but I really do believe that, this kind of really does fit with some of the findings in our paper. This younger population of, FITs and early career, there's just going to be a greater population of people who identify as LGBTQ plus compared to this, mid to late career or non-MD clinician, just kind of a lower, group not identifying or maybe not as out identifying as queer.
Yes, no, I mean, fascinating. And, I'm going to just piggyback your comment here and request you to take us to figure 1, just to finish the discussion on out or open in the workplace. I mean, and this is, again, a very good split. I mean, and kudos to yourself and all the authors for coming up with a figure like this, because it's very insightful for the reader. You see, so the split is based on medical school residency and fellowship. And it's fascinating that you're seeing this bigger part of the pie in medical school as not being comfortable or not being open yet. What do you make? What do you make of that?
Yeah, there's so many ways. This was kind of a question I'm glad I included, and there's a lot more that we could have asked, but there's so many questions that you can ask on a survey. You're right. So in medical school, about 23% say that they are comfortable being open and out. It increases 31% by residency and then 47% by fellowship. And it's, there's a couple ways you can look at this, right? In medical school, our LGBTQ plus medical students, they're being judged, right, by attendings. They want to make sure that they get an honors in their electives. So they're probably kind of staying in the closet and not coming out. And that is probably how I would really interpret this. And then as you kind of start to climb up the healthcare professional pole to a resident and then to a fellow, you're kind of more in a greater position of being in charge. And you don't have to worry maybe perhaps as much as about being queer in the workplace when you're in a sense of being, in an inferior position, kind of being at the bottom of the totem pole. And that's sad, but true, and there is a sense of invisibility as being an LGBTQ plus person in the workplace. Remember that when it comes to education of sexual and gender minorities, there is less than about 5 hours of teaching healthcare education about the needs of the LGBTQ plus person in the workplace. So why would I feel safe as a queer medical student about coming out to my peers? And that probably also fits in really nicely with these graphs.
Yes, congratulations on putting the table as well as the graph together. Is there anything in the results section you think we have not discussed that you think you want to bring to the fore for the listenership?
Yeah, I think there's 2 things. When we talked about those 2 specific forms of harassment, so we talked about gender policing and heterosexist harassment. So we definitely saw those 2 forms of harassment were obviously much more common with LGBTQ plus respondents compared to non-LGBTQ plus respondents. And what did we see? So the LGBTQ plus respondents were much more common to report hearing offensive jokes or remarks about lesbian women, gay men, or bisexual people in the workplace. They were much more common to report hearing remarks about your sexual orientation, either publicly or privately, hearing slurs regarding your sexual orientation in the workplace. And when they heard all these things, where did it come from? From multiple sources. Again, attendings, coworkers, and fellows were the most common. 42% were reported to come from attendings and coworkers, followed by physician leadership was 34%, nurses or advanced practitioners, 27%, and then patients, 26%. So it's everywhere. So to me, that is a really striking finding when it comes to this specific form of harassment. Otherwise, when we looked at that short negative acts questionnaire, finding other types of bullying in the workplace was actually similar between both LGBTQ plus and non-LGBTQ plus respondents. But these specific forms of harassment were much more common for LGBTQ plus respondents.
Yeah, I mean, it's sad. As someone who's the chair of a group at the college, I mean, where do you start? Like, what is the solution? I mean, does it have to do with someone's ability to be kind? Does it have to do with realization that, it could be a family member or, your kid, your cousin, your sibling, and having that kind of sensitivity? Or, I mean, where do we start with this? Like, what? I mean, because you can lecture and you can sort of create awareness, and that's important. I'm not taking anything away from those activities. Those are crucial. But then you still have these, what we call as locker room talks, or, behind the curtains, slander. And I think it requires a lot of, inner work, and character building, and also, sort of, who am I to pass these judgments, kind of mindset to really break down this behavior is my perception of this issue. But I'm going to stop and have you speak, because you're the first author on this great paper, and I'm sure you brought this in the discussion with your co-authors, which is a fantastic co-author panel, by the way.
Yeah, you're right. It's tricky, right? Because lectures aren't going to change culture, but one part is education, and I'll probably get back to that. But the other part is it's really creating a safe environment. And, yes, part of that includes creating a safe environment for the LGBTQ plus team, but it really can be creating a safe environment for all underrepresented minorities. You don't have to just say, oh, it just has to be for the LGBTQ plus trainees, but it should. You want to also create a safe environment for queer trainees. But the other way that you can look at this is that, as I like looking at that pie graph where more and more people are out in the workplace, one of the things that I did not have as a trainee in medical school and residency and fellowship, I did not have a what I call, kind of a gender identified mentor, right? I did not have a queer mentor. And that would have really revolutionized how things would have changed for me in cardiology, or even an ally, right? Not everywhere I'm going to find a queer cardiology mentor. But I think if at academic institutions or in private practice institutions, if there is a roster that people can go to, that people can safely say, oh, this is an LGBTQ plus ally. These are LGBTQ plus mentors. They don't have to be cardiologists, but somewhere that they can create really open visibility. And this will really kind of help kind of create that environment where queer people can really start to feel safe, and then other queer people may come out as well. And that might create a much more productive environment for LGBTQ plus people in the workplace. When it comes to education, there really is a lack of healthcare education curriculum. I truly believe this does perpetuate a sense of invisibility, especially to that young medical student who is not out and feels invisible in the workplace. Having education will also maybe kind of reduce biases from other people who have never even met a queer person or taken care of a queer person in the workplace as well. And then I think the last piece is having a strong academic support and institutional support. So if a queer person is experiencing any form of discrimination, that they know that they are in a workplace where they can share, wow, I was, bullied or discriminated against, and they know they'll get support for having that negative experience in the workplace. I think those would be some strong things that I would look towards to really reduce some of those some of that harassment that we identified in our study.
Yeah, absolutely. Excellent topic to study. A lot of effort in getting the surveys out, getting them collected, collating these data together, putting them the way you have, and then really parsing out what are some of the messages that have been delivered and what have we learned. Where do you see the college go with this? What is the stance of the college with this?
The college has been incredible. And one of the things that we mentioned in the manuscript, and one of the things that we are doing still, in fact, last Saturday, so I'm going to give, so that would have been, so on January 19th, we had our third annual, the American College of Cardiology has their internal medicine cardiology programs to, improve diversification of the field of cardiology. So we had our third annual LGBTQ plus internal medicine cardiology program. And so if you're not familiar with that, it's a method to introduce all underrepresented minorities. So we include our LGBTQ plus residents who are interested in the field of cardiology to both LGBTQ plus mentors as well as allies to the resources they may need to understand career opportunities in the field of cardiology. So we have a whole one-day program to introduce them to cardiologists in the field of academic medicine and to private practice, to cardiology fellows, as we do a round-robin session to introduce them into the field of subspecialty cardiologists as well. And we connect them to an LGBTQ plus mentor to kind of get them through residency, help them model their ERAS application. It is just incredible. And I know we just had this past Saturday. I think all the attendees really enjoyed kind of this whole session. And hopefully we'll kind of, from the LGBTQ plus program, we might hopefully kind of learn more from what are our applicants really getting out of this and kind of continue to publish data from our applicants as well.
Absolutely. And then I'm going to extrapolate the same question to you from an institutional perspective. What do you think can be accomplished, both at our organization or our institution, as well as others in the state and nationally?
Yeah, I think, so we use Epic as our electronic health record. And there's no doubt how easily sexual orientation and gender identity data can be collected from every single patient, and how incredibly important that is to be collected and how readily available that is. This is data that is just not collected routinely. There's so much data. There is literally, and I think why this doesn't occur in cardiology, there is literally a fear of physicians who think they may make mistakes with terminology. There's also a fear that patients don't want this data collected. We've published this before. I did a recent publication with my colleagues in the field of adult congenital medicine, where we did a study just asking our patients do they want to have this data collected? And there was an overwhelming response that, yes, our patients do want to collect this data. There was no fear of asking these questions. And there was no fear about what would this data do should it be collected in a research setting, and where would this data going? And this has been shown over and over again in the ER setting, in cardiology, in urology, so in many subspecialties. And I think that it's got to be, kind of squelched that this data shouldn't be collected.
Yeah. No, I mean, I think, so much can be garnered, I think not only from the perspective of, challenges and harassment, but outcomes and, how these patients are managed, with different disease states, particularly cardiovascular disease states. And I mean, it's a great disparities project, and should be undertaken. I mean, I've learned that Epic actually has a warehouse where there's crosstalk among all the institutions which use Epic, and you can collect sort of like nationwide Epic warehouse data. I don't know what it's called, but you can do that it's sort of big data, and you can collect nationwide from all hospitals who are using the same health system, collect these data to study this group, more comprehensively. So, certainly something which should be undertaken. I think we're going to learn tremendously when we're at the end of the day here for, both our patients as well as our colleagues. Well, thanks again for doing this, Steve. For us, congratulations on, such an innovative and such an impactful publication. You have any closing remarks for our audience, for the listenership, and for Parallax?
Yeah, I think that this was really an exciting study for us to do. Whether or not this, one of the things that's probably the biggest takeaway from this is that, whether or not this represents, the true prevalence of the LGBTQ plus population, we are not sure, right? This is how I would summarize this, is that this is the initial assessment of LGBTQ plus prevalence in cardiology. I mean, this is either a gross overestimate or an underestimate, because currently in the ACC, we do not collect SOGI data. So this is my first stab at trying to best assess what is the status of LGBTQ plus prevalence in cardiology. So hopefully we will continue this will not be the last time you'll see an assessment of the prevalence of LGBTQ plus folks in cardiology.
Well, thanks for leading the space, and thanks for, being the voice and the beacon, and congratulations again, and really proud to be your colleague, and keep up the great work.
Awesome. Thanks for having me.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app, or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.